Stacy, do we have permission to go a little bit over into lunch? Okay, great. Nabil is obviously a very tough act to follow. I'm a medical oncologist in the clinic, so I'm going to focus, but actually he provided a beautiful introduction to what's really our directions in cholangiocarcinoma research right now, and hopefully has introduced much more eloquently than I could some of the targets that I'm going to talk about, which we're now testing in humans in the clinic and are very excited by the promising signals to date. So this is the talk title, Immunotherapy and Other Targeted Therapies for Cholangiocarcinoma. And here's the outline I'll follow. An overview, as we've heard already from both Jessica and Nabil in different ways, about the heterogeneity, the huge variability in this type of cancer. Cholangiocarcinoma is really a family of different anatomic and molecular subsets. How do we use tumor molecular profiling and targeted therapies in clinical practice, both in cholangiocarcinoma and other tumors as a model? And then to really delve into some of the promising new targets and targeted therapies towards those mutations or targets for the molecular subgroups that we're understanding more about, which Nabil has introduced, including FGFR or fibroblast growth factor receptor inhibitors, isocitrate dehydrogenase 1 or IDH1 mutations inhibitors, several other targets, and then last but definitely not least, immunotherapy targets. So cholangiocarcinoma has always been an extremely heterogeneous disease from a patient perspective, from a clinician perspective, owing in large part due to its complex anatomy. And we know that the location of tumor, whether inside the liver in the intrahepatic bile ducts or around the entry into the liver, the hilum or perihilar or Klatskin tumors, as Jessica alluded to, or in the distal or distal extrahepatic cholangiocarcinoma, have very different behaviors, in part because of their anatomy and the plumbing associated with them. We often will diagnose extrahepatic tumors earlier because they physically block the flow of bile, and people get yellow and itchy and lead to a diagnosis before the tumor has metastasized in some cases. So the stage of diagnosis is earlier for extrahepatic. The location of tumor also impacts whether it can be removed by surgery, which may be easier for an intrahepatic tumor than something that's right in this business part of the liver where all the blood vessels and bile ducts coalesce and are very difficult to resect in some cases. And then further, the location of the tumor can impact both the side effects of drugs, particularly if the liver is not working well, or the risk of complications like obstruction and cholangitis, and need for stenting and other really complex clinical presentations. And another feature of cholangiocarcinoma, again, thanks to the great introduction from Jessica, are its many different causes. So we know that in certain parts of the world, the parasitic liver fluke infection is a predominant cause. In other places, inflammation, such as viral hepatitis and many other causes that we're getting emerging information about from Jessica's talk, and then in the majority of cases, unknown causes, also contribute to the heterogeneity of this cancer and the underlying host's liver. And increasingly, we are beginning to realize that the anatomy, as well as the cause, what incited this cancer, impact the biology, the molecular features of that cancer. And of course, taking this back to the clinic, it stands to reason that tumor biology, the underlying molecular features, could impact the response to the treatments we try. And therefore, we need to certainly learn much more about them. So again, following upon that last point, there are heterogeneous molecular subgroups of cholangiocarcinoma, not just heterogeneous anatomic or etiologic or cause subgroups. A recent study that was just published earlier this year from the International Cancer Genome Consortium performed a very complex whole genome RNA expression and epigenetic analyses of almost 500 cholangiocarcinomas from around the world, and is one of, if not the largest study of its kind. And we are very pleased and proud to have one of the lead authors, Dr. Binte, presenting this study in full tomorrow during one of the scientific sessions, if you're able to make it. And this study looked at about a third of them were fluke infected, and another 300 were other causes. And they found that they tended to cluster into 4 different groups, characterized in part by their mutation and gene copy numbers, as well as the gene expression and epigenetic profiles. Again, what Nabil discussed much more eloquently. And show us that instead of just the intrahepatic versus extrahepatic splitting that we've been doing all these years, there are really much more sophisticated molecular groupings of these cancers that may be clues to their biology, behavior, and treatment down the road. And so again, this slide isn't intended to be memorized or even necessarily visualized, but what it shows is they found that there were sort of 4 reproducible clusters, which they named 1 through 4, that had different mutations across each cluster. Cluster 4 was the one that had more of the FGFR abnormalities that we've talked about in IDH1, whereas cluster 1 had more BRCA1 and 2, which is a gene we see commonly in breast cancer, was more, and as well as P53 mutations in cluster 2 and so forth. And they also saw that these clusters were somewhat related to the location. So clusters 1 and 2 had more extrahepatic and a mixture of intrahepatic and extrahepatic and more likely to have fluke infection, whereas cluster 3 and 4 were mostly intrahepatic without fluke infection or exclusively without flukes. And so again, that's a lot of complex information, but what does it tell us? It tells us that these are very biologically distinct cancers, all within the bile duct. Our current chemotherapy treatments for cholangiocarcinoma are one-size-fits-all, meaning that we use the same drugs, whether it's intrahepatic or extrahepatic or FGFR2 or IDH1, and that has historically been our practice. We don't currently have any targeted therapies FDA approved for cholangiocarcinoma. That's not for lack of trying over the past decade or so, but prior studies in cholangiocarcinoma have really not shown a benefit, and I think there's a multitude of reasons. In part, there haven't been that many. It's been a pretty limited field of research owing to the rarity as well as lack of understanding of the cancer and the challenges. In parallel, the targets have been studied, have really been taken from data in other tumor types and not really specific to cholangiocarcinoma, may not be the most important targets in cholangiocarcinoma. And they've also been studied in a one-size-fits-all population, not looking at specifically a targeted drug for tumors with that target present, but rather in all cholangiocarcinomas does this drug work. And it becomes very hard to discern a signal if that drug even is active if you're looking at it in the whole population. And also, most of the studies have been done before we actually had the tools available to do good clinical profiling, not just laboratory profiling, but actually test human being samples for what mutations may be present. So in the clinic, how do we use tumor molecular profiling? And certainly there are many goals, but to focus on the principal ones, we of course want to find any information that we can about how is this cancer going to perform? Is someone at a higher or lower risk of it coming back after a surgery? And what is the survival expectation if someone has advanced disease? More importantly, though, obviously, from the patient perspective and my perspective as a doctor is, can we find something out about that tumor that will help us pick a better treatment that works better, works longer, and potentially someday could be a cure? And so we want to find the targets for therapy. And this is really followed upon early examples dating back to breast cancer when the HER2 gene was discovered. When HER2 is overexpressed, it's human epidermal growth factor receptor, overexpression of that protein or extra copies of that gene were associated with poor prognosis, but have significant benefit from antibodies or small molecule drugs that block that signaling pathway. And we now have evolved to have targeted therapies for many types of cancers that have really transformed the outcomes for people with these targets. Another notable example is EGFR mutations in lung cancer. We have a host of drugs in first and second and later generation inhibitors that can inhibit resistance mechanisms and can be sequenced in strategic ways to keep a target-positive cancer under control. And now, in the past couple of years, we've learned that some cancers that express PD-L1 protein have a better response from immunotherapy. They'll be cautionary and say that not all tumors require PD-L1 to respond, and not all high PD-L1 tumors do respond. So it's not a perfect marker, but it's a new marker in lung cancer in particular. So there are many other examples. So I wanted to, again, backing up a tiny bit just to make sure that I'm speaking in common terms. What is tumor molecular profiling? And again, Nabil covered this beautifully and much more eloquently, but from a very simplistic perspective, it's looking for a molecular abnormality that could be exploited or a weakness of the tumor that could make it susceptible to a particular treatment. There are many types, including DNA mutations in the coding of that cancer cell. which can be mutations like point mutations that just simply change one base pair, or fusions like we talked about with FGFR2, where genes are connected together in erroneous ways, or deletions where the gene is simply omitted. We can also look at tumor RNA testing. That's not really done much clinically yet, with a couple examples. And we can also measure proteins, or the end product of this DNA to RNA to protein pathway, to look for cells, to look for proteins on the surface or inside of cancer cells, to really understand what is the profile of that cancer, what are its biologic characteristics. So then when we say, what are targeted therapies for cancer, what do we mean by that? When we use standard chemotherapy or conventional chemotherapy, those are called cytotoxics, meaning toxic to cells. And cytotoxic therapies injure the cells that are dividing rapidly by interfering with their ability to replicate, and eventually kill the cells that are dividing fastest, and in the process can cause injury to our normal cells. So cancer chemotherapy can work very well in some contexts, but it clearly is not the final solution for most cancers. Molecularly targeted therapies are treatments which are designed to specifically inhibit or injure a particular protein or pathway that leads to a vulnerability or a weakness of the cancer and shuts down the cancer, and hopefully is present just in the cancer, not in the rest of our body, though sometimes that same protein or pathway can be active in other areas and lead to toxicity from a targeted therapy, even though it's pointing to a specific target, not all dividing cells. And so using targeted therapies, sometimes if a target is commonly present in a cancer, we don't need to do any special testing. We can use that therapy indiscriminately for a type of cancer. For example, if a tumor has very ubiquitous expression of a particular pathway, then that targeted therapy may be useful and helpful even without a particular test to show that it's there. But in small subsets where only 15 or 20% of a tumor or less of people have that mutation, we need to test to see, is it there, before we bother to put someone through the risk and the wasted time of a drug that's not likely to help if it's not there, if the target is not present. So in cholangiocarcinoma, we've started to see that there are reproducible subgroups of molecular aberrations or mutations which are susceptible to drugs that target them, or targeted therapies. And these include, as we've talked about, fibroblast growth factor receptor 2, FGFR2 fusions, IDH1 gene mutations, several others I'll come to in a moment, and importantly, microsatellite instability, or mismatch repair deficiency, which are synonyms for the DNA finding and the protein finding of the same pathway. So this is something I'll repeat again in a moment, but we often use MSI high or microsatellite unstable status synonymously with mismatch repair, because microsatellite instability is the DNA finding and mismatch repair protein deficiency is the protein level loss. So we can test the same thing in two different ways. So looking at FGFR gene fusions, these are present in about 15% of intrahepatic cholangiocarcinomas, and much rarer, if not at all, present in extrahepatic. And as Nabil showed us, they're caused by the inappropriate connection of the business part of FGFR2, which is a gene involved in cell growth, proliferation, and can cause invasion and metastasis if it's uncontrolled. So normally that gene needs to be tightly controlled to keep a cell under control. But if you accidentally, during the process of cell division, that gene, the business part of that gene, gets connected to a housekeeping promoter or the maintenance part of a normal gene that's highly expressed in the liver, for example, then FGFR2 can be turned on indiscriminately without any control mechanism and becomes independent of its normal control pathway. So you get uncontrolled ligand-independent proliferation of the gene, and that leads to cancer. So this table is not intended to be scrutinized in too much detail, other than to show that there are now a host of FGFR2 inhibitors in clinical trials, and we're very excited by early promising signals of activity across the board, suggesting that it is a true efficacious target. So I'm going to touch upon two drugs in particular that we've been involved with clinical trials of. and Nabil has mentioned both of them as well. One of them is BGJ398 infigratinib, which we'll hear more about tomorrow as well in the scientific session from Lipika Goyal, among other people. And the second drug is TAS120, a drug from Taiho. And these are two different types of FGFR inhibitors. BGJ398 binds in the ATP binding groove of the protein and is an ATP competitive reversible inhibitor, so it works by inhibiting the protein in one way. TAS120 binds in a different place and inhibits FGFR2 from a completely different location. So here's the phase 2 trial data with some updated results that Nabil showed. And from the clinical trialist perspective, I should give a bit of background that when we look at a plot like this, it's called a waterfall plot. And each one of these bars represents a patient who was on a trial. So in this trial, the updated results that are from summer of 2017 include 63 cholangiocarcinoma patients who had some sort of FGFR abnormality, some mutations, some fusions. Turns out that almost 80% of them had fusions, which are represented by these little clear circles above those bars. And if you look at this waterfall, the bars that are above the center line are people whose tumors grew, and the bars that go below the center line are people whose tumors shrunk on the drug. And as you can see here, the majority, the preponderance of these people had their tumors shrink on the BGJ398 FGFR2 inhibitor. And below this arbitrary threshold of 30% is considered substantial shrinkage. And it turns out that these were, the majority of these major responses were in the fusion patients, people with the clear circles, the actual fusion gene, and that they lasted a long time. So here's an example of one of our patients from UCSF who was treated on the BGJ398 trial. And as you can maybe see here, there's a pretty large liver tumor present, and she had multiple other liver tumors as well as pelvic and lymph node metastases, and had many prior treatments and was progressing after multiple prior chemotherapies. And then this young woman started the BGJ398 drug and had very dramatic shrinkage just after 2 months. If you can see, this is much smaller here than it used to be here. And that shrinkage lasted almost a year. And so while we wanted it to last longer, that was a substantial improvement in her tumor and achieved a significant duration of disease control. Now, I mentioned also the structurally distinct drug called TAS120, which binds FGFR in a different way. And so TAS120 has also been tested in FGF mutation and FGFR2 fusion patients. And these are results presented by Dr. Goyal, again, who will be speaking tomorrow at Barcelona in 2017. And in this initial cohort, there have been many more patients since then. In this first 23 patients, we can see also that for the red bars, these are the people who had the actual fusion. Most of the red bars had a tumor shrinkage, and a lot of them had a partial response or a substantial shrinkage, and those were also durable. And one thing that's very interesting, and it harkens back to Nabil's talk, is this asterisk here, which indicates that people who had had prior treatment and response and then progression on BGJ, the structurally distinct FGFR2 inhibitor, could respond after that to this different FGFR2 inhibitor. So that makes us start looking towards FGFR2 like we think about EGFR mutant lung cancer, that maybe there can be sequential serial targeted therapies if we can figure out from work in Nabil's lab and many others how these mutations of resistance occur, how to detect them, and find distinct FGFR inhibitors that can target them independently and use drugs one at a time. So this is one of my patients who I actually saw yesterday in San Francisco, who had a really nice response on the BGJ drug herself, not the same one I showed you before, a different person, and then had progression after over a year, and then started the TAS120 drug for her FGFR2 fusion. And after just 6 weeks, she had a very substantial response, and her pain went away. She was having a lot of hip pain, and this tumor here is an example of something that shrunk quite a bit. This particular one shrunk about 25% just in 6 weeks. So a very encouraging signal that a resistance to BGJ potentially could be overcome by a different type of FGFR2 inhibitor. So this is obviously very exciting, and there are multiple phase 2 and 3 trials of FGFR2 inhibitors now going on, and I showed you that kind of busy table at the beginning for reference. And so we're hoping that these drugs will reach the criteria for evaluation for potential approval with the maturation of this clinical trial data and potentially be available in the clinic in the future. Now, I should mention there are significant side effects of targeted therapies, and for the FGFR2 inhibitors, there are class effects including elevated phosphorus elevation that can require additional medication to treat it and can lead to calcium and phosphorus abnormalities. People can also get hand and foot and mouth soreness or even have fingernail changes or lose their fingernails. Most of the time manageable, but certainly another area that we can work on by trying to find more selective inhibitors in the laboratory and improve upon the drugs that we have to work with. So another new therapeutic target that has come up from Nabil's work in particular is IDH1 mutation. So IDH1 mutations occur, as you heard earlier, in about 20% of intrahepatic cholangiocarcinomas and almost never in extrahepatic. And what they, through a complex pathway of downstream metabolite, they block cell differentiation and lead to very immature looking or poorly differentiated tumor cells. And so this has also emerged as a potential therapeutic target. This again is a table, just a selection of clinical trials now ongoing for IDH1 mutant cholangiocarcinoma. The drug I wanted to talk about most is called AG120, which again you'll hear more about tomorrow. It's called ivosidenib, and in a phase 1 trial, about 70 some, I don't know if I have the number on here, 73 cholangiocarcinoma patients, 90% of which were intrahepatic, were treated with this drug, and it showed very tolerable side effects and prolonged tumor control. Substantial shrinkage only occurred in about 5%, as shown in the blue bars, but there was prolonged stable disease with a significant number of patients exceeding stability greater than a year, which again was very encouraging, particularly in a population like this who had had extensive prior therapy and had progressed on all standard, most of them had progressed on all standard chemotherapies, and average had had at least 2 or 3 prior treatments. So as a proof of principle that this drug is actually inhibiting IDH1 and making a change in the tumor cells, this trial also included biopsies at the beginning and after treatment with the IDH1 inhibitor, ivosidenib, and they showed that the characteristic poorly differentiated cells became more bland and differentiated on treatment, showing a proof of principle or a proof of mechanism of how the drug was working. And again, we're very fortunate to have a speaker who's worked with Nabil on this, Dr. Deshpande from Harvard tomorrow as well, to present this data. So the promising results from the IDH1 inhibitor ivosidenib have led to an ongoing phase 3 trial called Clarity with IDH, cleverly in the acronym here. And it's a randomized phase 3 trial with the intent to take the data, including overall progression-free survival duration, to the FDA for potential approval depending on the results at the end of the study, which again is very exciting. This is the first biomarker-targeted phase 3 randomized trial in cholangiocarcinoma and is a real milestone for where we want to go with the way we do clinical research. I will also add that while there's a randomization to placebo, for every 3 patients, 2 patients get the actual active drug and 1 person would get placebo. And in part thanks to advocacy from Cholangiocarcinoma Foundation and discussions about trial design in this forum a year or 2 ago, the agreement was to allow crossover from placebo to active drug at first progression. So people get scans at 6 weeks, and knowing that a patient no one would feel comfortable, doctor or patient alike, staying on a drug that might be a sugar pill if there's mild progression or profound progression. The trial was designed to allow people to switch over to be unblinded, and if they are on placebo, can go and get the active drug. And so this is a huge accomplishment because none of us want to put somebody on a placebo and not have activity. And so this gives both the science of being able to see and detect a difference statistically, but also a chance to be treated with active drug for everybody. So future directions for cholangiocarcinoma with the IDH1 mutations. As I mentioned just now, the Clarity phase 3 trial is ongoing and will determine the effectiveness of ivosidenib. It's also a very interesting drug from a clinical perspective that it has very mild side effects, and it might be something that would be tolerable in combination if we could devise a strategy based on the results in the laboratory that makes sense as a combination partner, such as with chemotherapy or other targeted therapies. And there's some early evidence that this mutation may be similar to a type of mutation called BRCA1 or DNA recombination defects that could benefit from a type of drug called PARP inhibitors, which are used in breast and ovarian cancers. That's very preliminary and based just on laboratory data right now, but there is a PARP inhibitor trial for IDH1 cholangio now in development. So I'll touch really briefly on a host of other promising targets in cholangiocarcinoma that could be so-called driver or truncal mutations that cause the cancer and therefore potentially susceptible to a potent targeted therapy and allow the cancer cell to be treated by or killed by targeting that particular mutation. There are a bunch of these and selected out from a study by Milan-Javli et al. Last year. We see in particular that, actually here, I'll focus here. ERB2 is the same as HER2, the breast cancer gene I mentioned earlier. That occurs in a reasonable number of extrahepatic cholangiocarcinoma, over 10%, and in a high number of gallbladder cancer, a slightly lower number of intrahepatic, but potentially a meaningful target because we know its activity in breast and gastric cancer. BRAF mutations, Nabil also mentioned, are present in a smaller number, but we know that that's a therapeutic target in melanoma and to some extent colorectal cancer, and also poses an interesting question for cholangiocarcinoma. And then there are a host of very rare fusions that are exquisitely sensitive to other fusion inhibitors like FGFR2 is. So how do we study such rare numbers? Basket trials are clinical trials that are designed to look just at a type of fusion independent necessarily of the tumor type, so that if you have a BRAF fusion, you potentially could go on a BRAF inhibitor trial that has a basket of tumor types enrolled, colon cancer, melanoma, cholangio, for example. And there are several of these initiatives going on, including the NCI match trial and TAPER, which have arms for various targeted therapies that allow any tumor type. And so the hope is that we can get basket trial data for some of these rarer fusions and use those to guide our directions in cholangio and hopefully develop cholangio-specific trials in the future. So last but not least, in the last few minutes of this talk, a new target in oncology is the immune checkpoint. How does our immune system learn to respond and react to cancer and recognize it? And this is a very complex topic that Nabil touched upon as well. It's not just the tumor cell, but it's also the microenvironment of our own host, our own liver around the tumor cell that determines whether our T cells and our other antigen-presenting cells of our body can recognize a tumor. A new family of drugs called immune checkpoint inhibitors have been developed and first approved in 2014 for melanoma, which block an inhibitory signal called the immune checkpoint that many cancer cells will send to our own T cells. And so basically cancer cells will make a protein that if a T cell comes by them, it will turn off or inhibit the T cell activation, and therefore the cancer cell can grow unchecked without our own immune system holding it back or fighting it. And so recognizing that unique pathway, inhibitors were developed, antibodies, to block that negative signal and let the T cell recognize its true target, which are foreign cancer cells that shouldn't be there. And so this one type of immune checkpoint inhibitor, there are multiple, is the programmed Death1 or PD1 and PDL1 inhibitors that were first approved, as I said, in 2014 with the drug Keytruda for melanoma. And now there's a long list that I need to struggle to keep updated because so much efficacy has been seen across different tumor types. So one important group of patients that benefit exquisitely from checkpoint inhibitors are mismatch repair protein deficient tumors. And so mismatch repair protein deficiency is due to DNA mismatch repair gene mutations leading to errors in our DNA processing and copying throughout our genome. And this can be due to a hereditary mutation. One of the audience members mentioned Lynch syndrome. That's a hereditary condition where people are born throughout their body with a mismatch repair mutation, or it can be acquired in the tumor where it just happens in the tumor and not in the rest of you. But when people have mismatch repair protein deficiency, It causes a high rate of mutation in recurring stretches of DNA throughout the genome and throughout the cancer. And those DNA changes can actually lead to the creation of new proteins through something called frameshift mutagenesis, where mutant proteins are built that look different and look foreign to our immune system. Actually, I forgot to mention one key point, which is a challenge of the field, is the incidence of this, as I again mentioned to our audience member, that the likelihood of having mismatch repair protein deficiency, whether inherited or just spontaneous in the tumor, is very low, only 2.5% for cholangiocarcinoma. It's much higher, say, for colorectal, where it's about 15%. But in that 2.5%, the response rates are quite remarkable. So this is a study that shows, as I showed before, a waterfall plot where all these down bars show the extent of tumor shrinkage. So in a solid group of solid tumors, a basket trial, as I mentioned before, including cholangiocarcinoma right here. So it's a small number of these patients were cholangiocarcinomas. The checkpoint inhibitor pembrolizumab elicited a dramatic response rate of 53%, including 20% of patients, over 20% who had complete responses. And this led to FDA approval for pembrolizumab in solid tumors with mismatch repair deficiency. And this is the first tumor agnostic, meaning independent of breast or colon or gastric, across all tumor types, DNA or mutation-specific approval by the FDA. And warrants MSI or MMR testing for cholangiocarcinoma, because even though 2.5% is a small number, it is a meaningful benefit because the responses can be dramatic and sustained. Here's an example of one of my patients who had a spontaneous or sporadic MSI high mismatch repair deficiency in her tumor, not in the rest of her body, who had widely metastatic disease that progressed on standard chemo. She had cardiac metastases, bone and lung metastases. Here's 3 liver spots. She went on pembrolizumab on a clinical trial, and after 2 years, there was no residual tumor anywhere that we could find on PET scan, on MRI scan, on CT scan. So she stopped the drug, and as of right now, she's approaching 4 years with ongoing complete response. So again, a dramatic benefit. So now I'm finishing up too. So how will we know what to do about the other 97.5%? Do we say that immunotherapy won't work? No, that's not the case. There can still be responses even without mismatch repair deficiency, but they're much less common, and we don't know what the other biomarkers are to predict who those people will be. There's a large trial called Keynote-158 that's looking at 100 predominantly mismatch proficient, so not deficient tumors that will report sometime this year and will give us a hint of what the actual response rate is in non-deficient patients, and give us biomarker data predicting who the other people are who might have these exquisite responses. But I think we can presume also that for people who don't respond, whether deficient or proficient mismatch repair, we may need other strategies and combinations to achieve these responses and help the immune system find that key to recognize the tumor. And there are multiple clinical trials ongoing that are quite exciting. Again, not a table to scrutinize in detail, maybe afterwards, but there are a host of trials with predominantly checkpoint inhibitor antibodies combined with T cells, autologous T cells, other checkpoint inhibitors, a growth factor, that's one we're doing at UCSF, targeted therapies like FGFR inhibitors for FGFR patients, chemo, antiangiogenic or blood vessel blocking drugs, stroma depleting agent, and another targeted therapy, a MEK inhibitor. So again, a lot of work being done, and we're going to have a lot of data to review over the coming years. I think second to last slide, another novel immunotherapy approach that bears mention is autologous tumor-infiltrating lymphocytes, or TILs, which is a type of adoptive cellular therapy where at the NCI, among other places, in the Rosenberg lab, they are perfecting the strategy of removing a piece of tumor, finding T cells that are reactive to your own tumor DNA sequences, and then growing up those T cells out of the body, and then reinfusing a large number of them into the patient to augment your own innate immune response and add checkpoint inhibitors to it. So it's a fascinating, very advanced approach to the immune therapy. So in summary, Where do we stand with targeted therapies for cholangiocarcinoma in 2018? There are very promising signals of efficacy from FGFR2 fusions, IDH1 mutations, and of course, as we talked about, mismatch repair protein deficiency for immunotherapy. Some of these drugs may achieve FDA approval in the future. There are many other potential driver mutations that need further study. We think that about 40 to 50% of intrahepatic cholangio patients may have a mutation that's targetable. It's a lower number for extrahepatic. These data do warrant molecular profiling if you have cholangiocarcinoma, particularly for MSI, MMR, even though the likelihood is low, and for these other targets that have advanced stage clinical trials going on. Our practice is to get tumor sequencing as soon as someone needs systemic therapy to try to send a tumor sample for testing. And it's important to make sure that the panel being used includes full coverage of FGFR2 because translocations can be difficult if they're not because they're not usually in the coding region, as well as for microsatellite instability or the mismatch repair protein status. So this is a rare cancer. Making further progress will really require collaboration and using basket trial mechanisms, multiple cohort trials, and expanded access to clinical trials through outreach and work from groups like Cholangio Foundation. I think we talked a little bit about the type of testing being done, and right now we prefer tumor testing, but it's very exciting also to see cell-free DNA plasma assays on the horizon that may be able to detect some of these mutations through non-invasive means over time, or increasing numbers of them. And finally, the message that these trials and targeted therapy is possible in cholangiocarcinoma. That wasn't believed before. It was too rare, too complicated, but that's not true. The Clarity trial, the randomized phase 3 targeted therapy trial is proof of this. And so with conclusion, there's huge promise and work ahead in this disease, and it'll be very exciting to be here in the years to come. Thank you.
Treatment in the landscape, but if she can answer probably a lot easier, a little bit more general questions than specific questions about your treatment, if that makes sense. Also, I wanted to just remind all of you that all of these presentations are going to be available on the website. So all of this you will be able to access. Okay.
Thanks. And I don't want to stand in the way of lunch, so feel free to make your way to the front of the line too.
I'll try to keep my question as general as possible, but I'm post-transplant, and I was originally diagnosed with an extrahepatic cholangiocarcinoma, and proceeded through the transplant, staging surgery, and then proceeded to have a transplant just a couple weeks ago. But post-transplant, when they did the pathology report, the tumor was present intrahepatic, extrahepatic, in 5 out of the 8 lymph nodes and in the gallbladder, all of which were removed. So my question generally is, when you distinguish between intrahepatic, extrahepatic, and gallbladder geography of tumors, how does that apply to someone where it's in all of them? And then now I'm waiting for my Foundation 1 sequencing to come back to see how to proceed. But because I've had everything removed, and I'm post-transplant, I've been advised immunotherapy and TILs and some of these other targeted therapies are off the table for me. So what would be the role of genetic sequencing in Foundation 1 for someone that's post-transplant, but had present active cellular growth or tumor growth in their explanted liver?
I think that's a great question, and it's not just an individual question because it is often very difficult to tell clinically if a tumor is advanced, whether it started right at the base of the liver in the hilar area and grew up into the liver, or whether it started in the liver and grew down. And sometimes there are clues like an area of dysplasia that may have started it that's lower down that we think, oh, that's where it started down in the extrahepatic area, or it started up, there's dysplasia in the intrahepatic area. Sometimes there are clues on the pathology or on the scan scans that tell us which way it came from, but often tumors right in the hilar area could have started intrahepatically or extrahepatically. We're never 100% sure. So I think it's important to get the tumor sequencing because it's impossible to tell whether your tumor, exactly where it started from a cell of origin perspective, and there may be a target that's useful down the road. Whether to do that sequencing now or cross your fingers and hope there's no recurrence, I think that's a different question, but I think it's warranted to do the testing if you ever need chemotherapy for recurrence, for example, in the future, which again, hopefully there won't be. From the post-transplant perspective and the question of adjuvant therapy, there will be a talk on Friday about the latest adjuvant data, whether it helps after surgery to do additional chemotherapy, and that's not yet tested in transplant, but worth discussing with your oncologist. And then lastly, for people who've had a transplant, it's true that there's a risk of rejection with immune therapy. As you might imagine, you have a foreign liver, and if we turn on the immune system more, that could cause rejection. So right now, it's considered a relative contraindication.
On the FGFR inhibitors, your slide suggested that increased phosphorus looks like it's a problem with all the FGFR inhibitors. Are there any that don't have as much of that, or are there any that are being developed that you know of that have less of a chance of creating bone problems?
That's a great question. It's thought that, so most of the FGFR inhibitors target not only FGFR2, but also FGFR1, 2, and 3, and maybe to some degree 4, depending on the specific inhibitor you're looking at. It might be that the phosphorus is most due to the FGFR1 component, and so theoretically it might be possible to develop a more selective FGFR2 inhibitor down the road that doesn't have so much phosphorus activity impact. Right now, all of the inhibitors that I've seen the data for have the same class effect of substantial rates of hyperphosphatemia, meaning high phosphorus in the blood. Most of the time we can control that with a variety of binder, other pills, vitamins to lower your phosphorus or diet changes. And so most of the time it's manageable, but it's a class effect for sure of the current generation.
Hi. I just want to jump back to transplant real quick. I'm intrahepatic, just had a transplant. I'm currently taking the mTOR inhibitor, everolimus. I don't know if that would be considered adjuvant in your mind. I take it as an immunosuppressant because it's indicated for that. Because my understanding is that it targets the PIK3CA gene in renal cell. So I don't know if that's something you're going to talk about more. If it is, I'm happy to sit down, but I just... I guess my question is that something that's being researched? Have you heard of that? When I researched, it's been scant. So
we don't have much data for optimal immunosuppression from a cancer recurrence perspective in cholangio. It's true that the Rapilog or mTOR pathway family of immunosuppressants also have anti-proliferative activity in our cancer drugs in other tumor types like neuroendocrine tumors and breast cancer even. We use everolimus, for example. For post-transplant in liver cancer, which is a much more commonly transplanted cancer, there was a large randomized phase 3 trial that looked at mTOR inhibitors versus other types of immunosuppression, and there didn't seem to be a recurrence risk benefit. We always hoped there would be.
Sure.
So I think really the right immunosuppression is what your transplant team thinks is best for the liver's health. And right now, we don't know of it as an anti-cancer strategy, but there has always been this anti-proliferative activity of mTOR inhibitors that makes them rationally appealing.
Yeah, I mean, that is part of the reason why I'm taking it. It's not just from the immunosuppression aspect. It's to hope, I guess. And I was just curious if the mTOR was the only pathway, because I know it, or if I did not have that particular, if someone did not have that particular sequence or mutation, would it not be? Is this too specific?
It's not too specific, but I think mTOR is a lot of different pathways lead to mTOR path activation, including PIK3CA. So
Sure.
I think it's a very reasonable immunosuppressant to be on.
Okay.
Either.
I'm pretty new at all this stuff, so this might be a dumb question, but I'm wondering if you get the Foundation 1 test done, is that something that should be done again? Could it change at some point?
So I think Nabil mentioned this earlier, that generally we think that a lot of mutations, if they are present in the majority of tumor cells, are part of the cancer's machinery or like the trunk of a tree mutation, something that was there when the cancer first started. And those are usually the most attractive therapeutic targets because they're clonal throughout the cancer and most susceptible to treatment. Those usually are present at the very beginning, but resistance mechanisms to target therapies can arise over time. So like Dr. Bardisi showed with the FGFR2 kinase domain mutations, there may be a role in the future as our use of FGFR2 inhibitors expands from the clinical trial realm, hopefully to practice someday. We may start testing for resistance mechanisms, either in the blood or in a repeat foundation. Right now, that's purely in the investigational realm, and so not yet a practice. Also, sometimes the first sample, a biopsy sample, may have very scant material, and if you look at your foundation report, it may not have enough tumor to do a full testing, and so in those cases, I will often repeat the test at progression to make sure we get as good a sample as possible and test for everything. And
So mine kind of goes off of what you guys were just talking about with the genetic testing and finding out, your mutations and whatnot. A lot of us have a list of the unknown significants that are listed. My question is, are these significant? Do we need to look at these? Do they play a role in, or can they play a role into cholangio, and what treatment options may be available in the future?
right now, we don't really know how to, the variants of unknown significance in a foundation report are just that. We don't know what to make of those, and they're pretty thorough about including the ones that have any clinical data as an actual significant finding. So I would say just to periodically, you could, if at the time of another treatment change, if you bring it to your doctor and say, any of these look like they've any emerging data on these, that would be what I would do.
Okay.
Hi, Katie. My name's Jocelyn, and I'm Colin Reese's sister. Our other brother, Bren, was just up here as well. And the question I have for you is less about sort of these studies and potential mutations that'll drive treatment pathways, but it's more about a sort of an outstanding question that I've had for quite a while now, which is that I understand that there's a number of variables and the sort of the type of cholangio you have, its location, its size, et cetera, that contribute to whether it's going to be operable or not. But just even in being here in less than 24 hours, I've sort of come into contact with people who have had surgeries where their cancer seems similar. Obviously, there's nuances, but similar sort of transparently as to Colin's case. And so I'm wondering if there are certain forms of cholangiocarcinoma that just across the board are not going to be operable, whether we're talking about resection, whether we're talking about transplantation, even bile duct reconstruction, which I've heard people do, or we haven't come across surgeons yet that are a little bit less risk adverse, more renegade in their approach to addressing some of these cases. And I'm not trying to put you on the spot here. I'm just curious about your take.
No, I think it's an eternal challenge to determine if a tumor is resectable or not, especially at the beginning. And it really depends on a multidisciplinary review, including people looking specifically at the blood vessels and the ducts and the drainage and exactly where the tumor is. But some key high-level principles are if a tumor has spread outside the liver beyond, even to lymph nodes, it needs to be carefully discussed. If you know that in advance it's in the lymph nodes, though it's potentially resectable, it's definitely a stopping point to really discuss, is this truly localized? If it's beyond the liver and the regional lymph nodes, there is no benefit from resection. It's metastatic disease and needs chemo. And again, in the vast majority of cases, there can occasionally be rare exceptions, I'm sure, but just in the general principle is that the curative therapy is for tumors that have not spread. And then within the liver, tumors confined within the liver, if tumors are multifocal with sort of satellites that are in both lobes of the liver, it's usually not possible to get a complete resection of all of those spots without fatally damaging the liver. And so it's the distribution and the spread And then sometimes a small tumor in the worst spot might not be transplantable. So, again, this is really a tough question that tumor boards around the world struggle with for this disease. But we do have a surgeon coming on giving a really nice talk on intrahepatic cholangio and these surgical questions on Friday, including is there a role for chemotherapy to help downsize and I think touching upon the questions you have. So Friday morning there'll be a talk on this.
Great. Thank you so
Thank
much.
you.
One quick question maybe, and for you and Nabil together, maybe it's not really targeted therapy, but while we're talking about genetics and things, are there any studies or can you speak to anything about the mutations that, I've heard at other conferences in previous years, things like KRAS mutations, KRAS variants of the cancer are less susceptible to radiation treatments. Radiation doesn't work so well if you have KRAS. There seems to be a lot of different variations among people in the aggressiveness of the cancer. Is that related to are certain mutations associated with a more aggressive form of the cancer? Those types of things. Any other, versus targeted
Yeah.
therapies, if you've got these mutations, here are some of the characteristics that we see.
I'll definitely let Nabil discuss KRAS because that's a common challenge in other cancers as well, including pancreas in particular. But some mutations do have prognostic impact, meaning impact how people respond to regular chemo or likelihood of recurrence after surgery as well. And so it's definitely the tumor biology plays a big role in outcome, even outside of targeted therapies. So if you'd like to add to KRAS.
Is this on? Yeah. I think that because there's such a diversity of mutations, that it's not really clear how a lot of them might affect just outcome in general. I think the numbers are probably close to being there, but I think the hunch is, for example, that FGFR2 tumors tend to be more indolent. I think that's been largely confirmed, but I think for KRAS mutant tumors, the issue with KRAS, of course, is that it's a very specific mutation, but currently there aren't any drugs that are clinically viable to inhibit KRAS. So I think that we don't totally know the relationship between genotype and clinical outcome, but this is certainly something that's being modeled, and that's going to become clear in the next couple of years.
So with that, should we invite people to lunch?